This is the Rising Stars Show with Rex Wallace.
Hey everyone, welcome back to Rising Stars. I'm your host, Rex Wallace, and today's episode is all about drugs, which our producer, Stefan, is super excited about because he thinks it's going to be major clickbait and we're going to have tons of subscribers. But actually, we're focused on the Part D side of quality today. And to have that conversation, we've got some really special guests today. First, I want to bring on our co-host and the CEO of Hyperlift, our sponsor, Mick Toomey. Mick, welcome back.
Thank you, Rex. Happy to be here.
Good to be with you again. And then our three guests. So let's take them in this order. So first off is the lead executive for Medicare at Arkansas Blue Cross and Blue Shield. Also former director of STARS there. So STARS background. And also one of three pharmacists we have on the panel today, which we had two scientists last time. We have three pharmacists today. So Mick, I'm thinking maybe four astrophysicists next time, but we'll see.
Like that.
Let's see how this goes. But but please welcome Lauren Dixon from Arkansas Blue Cross Blue Shield. Lauren, thanks for being with us. And then we have the Chief Quality Officer from the Pharmacy Quality Alliance, otherwise known as PQA, also a pharmacist by background, Lisa Hines. Welcome, Lisa.
Thanks, Rex.
And last but not least, the CEO of PQA, also a pharmacist, Micah Koss. Micah, great to have you with us today.
Yeah, thanks, Rex. Thanks for having us.
So, Micah, let's start with you because, it's possible that, at least one of our 4 subscribers on YouTube does not know who PQA is, right? So curious if you can kind of lay out who is PQA? What role do they play in healthcare quality?
Yeah, I've been at PQA for a little over a year, and it's been a great transition, and I've really been able to answer that question for myself as much as I have for external folks. So PQA was formed in 2006. We were formed out of a public-private partnership with CMS, and our original call was to develop pharmacy performance measures that could be used and to grow value-based agreements and really improve the quality of medication use. So from that, we've really transitioned over to a membership organization. We've got about 250 member organizations that are part of PQA. And people come to our table from a lot of different angles and from a lot of different walks of life, and they're all focused on improving medication use. They're focused on medication adherence, medication safety, and improving that. And so our table's broad. One of the reasons I came to PQA to join these fine folks is because of the broad nature of our stakeholder convenings and how we do things. We do it well because we involve everybody in the process. And so PQA has really developed over the years. We've been focused on adherence, and that's really where we're known for. But PQA is doing some really innovative things, and I'm excited to have our folks share a little bit more about that as we go through this conversation.
Me too. Yeah. Definitely want to dig into that because I think the role you play is super important, and I'm not sure everyone really appreciates that and really understands that. So Lisa, on that same vein, what can you kind of describe? You guys are the measure stewards for many of the Part D measures, including, like Micah said, the medication adherence. Can you talk about that process? What's that like to develop measures, to have, I know you have panels of plans who help with you, who help kind of develop those measures, test those measures, then CMS adopts those measures. You're the steward for those measures going forward. You get to read all the comments that come back from plans, right, during a comment period after the regulations come out. Can you kind of talk about that process?
Yeah, I mean, like Micah said, the beauty of our process is the extensive stakeholder vetting, and not just member organizations being involved, but also a public comment process. It's rigorous, evidence-based, transparent, and consensus-based. And by the time a measure gets through our various panels and comment periods and stakeholder feedback, it meets the criteria of a good measure. And then it's endorsed by our membership. So it's a rigorous process, and we're really proud of it. Actually, I don't know of any other organization that does what we do in terms of the vetting involved in our measure development process. And then the comments, love the comments from the health plans. I used to take it personally, having a sense of ownership related to the measures, but now I love the comments. Keep them coming. The more feedback and comments we get on our measures, the better the measures and the better our education and messaging can be. So that's the important part of being a measure steward, is seeking and incorporating feedback.
Yeah, that's got to be an interesting part of that, and I know a lot of plans, in, like Micah said, what 250 plans are, right, or stakeholders, or 250 entities or stakeholders. Lauren, I know, I know you've got some involvement with PQA. You're close to this, whole process, and I'm really curious because previously you were head of stars only, right? Only, right? That's a lot, but you headed up stars and you were very involved in PQA, in helping to shape some of these measures, I think, right, and very influential and just very involved. Now your role is expanded, and you're actually over all of the Medicare products at a health plan, much broader role, yet you are still very involved in PQA. So clearly, there's you're seeing some value, right? I assume it's because of the influence you're able to have and just the visibility you have. But can you talk about, I guess, what that's been like, and why you stay so close, why you stay involved?
Sure. So I think there's a significant value from a health plan perspective to be engaged with PQA along that measure development timeline, and even after it's implemented. There's so many phases that Lisa mentioned that allow for involvement. The initial development of a measure, kind of the think tank of what should come forth in the future. What are maybe health plans looking like? How do you influence what measures might be coming down the pipeline or could be developed? Then that actual development and testing of measures. So both, what is the denominator? What's an exclusion? What's appropriate clinically? And then taking the data to be able to say, like, this is what we see. Like, this may be an opportunity to improve the measure. And then I think there's a few other areas for that kind of key involvement in plan activity, both with a measure update panel. So allowing influence after a measure has been approved to say, hey, we've had it in testing. It's been here for 2 years. We've all been using it. And this is an opportunity that we're seeing. And to be able to kind of influence that result. And then ultimately from a QMAP perspective, which is the governing body, over all of those measures to help kind of decide how to move forth and share that expert opinion relative to the development. All of those phases are critical because ultimately at the end of the day, the PQA measures are used in CMS programs. They're also used in some state Medicaid programs that therefore impact overall plan reimbursement through things like star ratings or potential penalties or other factors. So having that ability to be able to influence the measure appropriately, but also know what might be coming. Okay, this is something that's being looked at. Opioids are a high priority focus for clinical quality measurement. Allows that flexibility to prepare, to engage, to influence, and to partner on kind of that opportunity to see in advance what's forthcoming and what's most critical to practice. I think the one other thing, while we're focused on measures, but I think it's really also key for plans is that testing. And also the grants and the other opportunities that PQA has for kind of that collaboration. There's just such a number of ways to be involved and to influence the process and to be able to prepare best and then ultimately impact patient care at the end of the day, which I think is everyone's goal.
Yeah, I think that Lauren learned that a secret sauce is to be engaged in measure testing. You get early insights into what your performance might be. You can influence by providing recommendations on specifications. It's really the way to stay on top of what's coming. And Lauren's not ever surprised what's happening in the Part D space because she stays engaged and involved.
Yeah, that's so important, and it's something we all want, right? And we don't always know how to do that, or I think entities like PQA, like NCQA, like even CMS, right? I mean, I think the closer we can be, the more involved we can be. Obviously, it helps all of us. I mean, and we have, like Lauren, like roles at a health plan where we're helping to shape the strategy, across, all of these Part D measures, Part C measures, and broader focuses as well, obviously. In this in this podcast, we focus primarily on Medicare stars, and though we can easily touch on Medicaid and QRS and everything else as it relates to quality, right? But in Medicare, yeah, a hot topic right now is obviously the final rate announcement that came out recently, early April. As of the date of this recording, we're still waiting on the final rule. It'll probably drop as soon as we hang up, right? But it should come any day, we think. But I do want to take a second and I don't want to get into the weeds on the final rate announcement, but there are some important themes in there and directions that CMS is heading, with the influence of PQA and other entities, and with the support of, I think a lot of health plans too, especially with this focus on Medicare beneficiaries, MA members who historically have low or poor clinical outcomes, poor low quality, right? And it's because of lots of barriers that come with their situations, and these are social risk factors, right? Socio-demographic status, socioeconomic status, and there's a big focus on health equity in the final rate announcement. More and more coming. It's there's the health equity index, there's the stratification, there's risk adjustment for socio-demographic status that you guys are pushing, I know, at PQA, and encouraging and testing. Can you, and Micah, maybe we start with you, but can you kind of talk about how, I guess the role PQA has had in that direction, and just it feels to me like we're heading in the right direction. It's the right focus we should have, and just any kind of forward thinking there that you can share.
Sure. This is one of the ideas that our team has definitely doubled down on, and our organization's squarely focused on. Our board, in our Blueprint 2025, which basically is our strategic plan between now and the end of 2025, one of our four main pillars is going to be focused on health equity and PQA's role in that. We think that there's a huge opportunity here to close gaps in care, to improve care for patients that are historically underserved, patients that struggle with access to care. Medication use is such an important component of it, but there's so many issues upstream that affect downstream medication use. We're talking about transportation, food insecurity, things that affect a patient's ability to afford their medication, to fill their drugs, but to take their drugs and to get the benefit from them. So from a health equity perspective, obviously we've done some work on risk adjustment, and we've made some recommendations to CMS. The next line of focus whenever we're looking at how we apply those to measures is stratification and what that looks like. And our team's very interested in engaging in those conversations about stratification of measures and what that might look like for certain populations. We know that you could even look within subsets of patients and identify gaps and disparities. So one subset of patients may have better access to medications than others. And so we know that there's probably some gaps that aren't being addressed that we'd like to take a deeper dive into. And so our team's very focused on that. The other thing that we're really focused on, I would say, from an engagement with plans and our membership community is we have a project that's a really neat project right now. It's done in partnership with PCORI, and it's focused on engaging patients and pharmacies in how to address SDOH and those factors that affect social determinants of health. And how do we engage pharmacies in that process and bring them into the fold to capture that information and then also do something about that information. We released our SDOH resource guide earlier this year and got some really good traction off of it because we offered 20 examples, real life examples of how medication use and SDOH are intertwined and how you can make a difference. And these are not, I would say some of them are more complex than others, but some of them are basic, but it's just making it a priority and focusing on it. So our organization is very focused on that. The work with PCORI is done in partnership with the Patient Advocate Foundation. And so we're excited to engage patients in a very real and visible way, especially through a reputable organization like PAF. So we're excited about this. There's a lot of work that we could touch on and we could probably spend all day on, but those are a couple of highlights of where our team's focused.
Yeah, that's helpful. So staying kind of in that realm, right, in that topic, and Lauren, I think I'll point this to you. Hopefully you, because I think you're especially owning Medicare and owning quality, and I think you even still have your hands in Medicaid quality too, right? But Risk adjustment. So I think some of our people, we talked about risk adjustment for socio-demographic status, right? So pretty basic question here, but can you help some of our listeners understand what's the difference between risk adjustment for some of these measures and risk adjustment at the Medicare side when we think of risk adjusting for for risk revenue, et cetera?
Yeah, so I think those terms commonly get confused when you're talking about two different teams, because typically you don't have the same people working on risk adjustment that work in the detailed Part D star space. But so risk adjustment for a plan is essentially evaluating the level that a plan might have for their risk and what their chronic conditions are based upon the medical diagnoses that occur, and adjusts revenue as appropriate to say, these members are sicker, that potentially may cost more, and really uses the medical diagnoses to determine that and to make that determination. Although I think they're certainly kind of looking at SDOH from a risk adjustment perspective. Risk adjustment for measures, while the same term obviously causes quite a bit of confusion, maybe could have been reworded at the very front end to make it a little bit easier, but it is what it is. Risk adjustment for measures truly probably looks at the population beyond those factors that are just their chronic conditions. It's looking at what are the levels of socioeconomic factors that are being considered that could adjust the quality of care that's potentially provided to a member. If someone is in a rural population, if someone's in this different economic background, if there's other factors at play that may have an impact on the overall care that could be provided, really looking to say, what's the adjustment factor to consider for the measures? What are the various considerations that can come into play? Because there are impacts. As much as the goal should be to remove those impacts and to continually push to make sure that we're providing everyone the most equitable care and resolving everything, looking at that level of difference from a measure perspective is kind of, I think, what PQA is saying they're doing from a risk adjustment, and then finding ways to overcome that moving forward.
Yeah, I think it's so important, right? I think to be able to risk adjust for, well, I guess to be able to, and this is what CMS has said in the final rate announcement, that they want to find ways to incent plans to serve these populations better, right? These and maybe not shy away from them, or not feel like they're being penalized for having high populations of members with lots of social risk factors and challenges. So yeah, I'm definitely glad we're heading that way. I know with the Health Equity Index, which I think will be great too, but there are some caveats to that, some nuances to at least to the proposed future looking plan, where it actually would potentially replace the reward factor in stars. And I do want to dig into this just a little bit here, and Mick, I want to actually get your take here too, because I know you are with your clients analyzing stars projections and taking all this the improvement measures and the reward factor into account. This would massively change that reward factor calculation, right? What are your thoughts on this?
Yeah, I mean, I think it has the potential to massively change it, and massively change the way we think about it, the way we manage it. You look at some of, frankly, there's still a lot of uncertainty and kind of a lack of clarity on how this is actually going to play out, right? But, we put a lot of focus on optimizing that reward factor. And for a lot of our customers, that adds, 20, 30, 40 basis points to their score, which is obviously a meaningful impact. And so if this thing changes fundamentally, going away from mean and variance to more of the social risk factors, the health equity index concept, there could be a big change. And I think a lot of it's still up in the air, and just to figure out how do you best manage it? Because if you're used to getting 30 and 40 basis points for that, this is all going to shift. It's going to take a whole new focus to figure out how to optimize that based on your population and who you've got on the plan.
Yeah, I think.
Oh, sorry.
Go
I was
ahead.
just going to tag on to that. I mean, I think what you said is key. It's a really interesting proposal from CMS, and I think something that we all should be pushing for, providing care that's the right level of care necessary for the member to get to the health outcomes that they need. Making sure that you're intervening, that you're resolving the social determinants of health, and you're not just saying, hey, fill your medication, but you're understanding what are the root causes that might impact that, and you're helping to resolve the root causes, which ultimately leads to care downstream. I think, though, Nick, you hit on the key point there. It's how are you going to measure this? What are the details? When's it going to be implemented? Is it truly going to replace the reward factor? Is there kind of this level in between? There's still a lot of ambiguity there, but I think if you look at what they're trying to do, it's what we all say we're trying to do. We're trying to provide the best care to the member and resolve the root situation, not just always seek to what the measure goal is.
Yeah, allowing them to, it's really kind of shining a light, putting an emphasis on making sure that we really are doing everything we can to best support this population. And again, we always come back to how do you manage it? How do you make sure that you're executing well on this? And it is going to, force plans to take a hard look at how they're serving that population, and how do you, what adjustments do you need to make to continue to be successful with all of this?
Yeah, and I think it's I think it's absolutely the right thing to do, and I think it's going to put the focus where it needs to be. I think when you think of plans serve these populations at different levels, right? So this is going to, I think, it's going to affect plans in different ways. I think plans that have high populations of members with social risk factors, this is going to bring more parity, right? More equity even at the plan level, right? And by providing at least the opportunity to have some boosts to your score, if you do it right, if you do a really good job of removing barriers and improving care for these members. Plans that don't have many members with social risk factors because of the states they serve or the areas they serve or the products they offer or a myriad of things, it's going to cause them to completely change their strategy, I think, right? Because I know a lot of plans who without the reward factor would still be around 4 stars, but the reward factor, like Mick was saying, can be at 40 basis points, which can jump them to 4.5 stars, right? Like that's how a lot of plans achieve 4.5 stars, is by that reward factor. But this is going to completely change that. If that goes away for certain plans, it's going to make them, I think, have to counterbalance that effect, right? That loss by really, I think, it's going to make them focus on the few members that they do have maybe in this population. But yeah, I think it's a really important element. I know a lot of plans that are thinking a lot about it. But Lauren, at the plan level, are you doing anything different to kind of prepare for that? I mean, you have a pretty big population of members with social risk factors already, I think, right? So, but what are you doing differently kind of to prepare
Honestly,
for that?
I think our initial strategy and the initial development we did here is preparing us for it. We're not necessarily changing anything right now. If anything, we're just re-emphasizing what we do. And our team knows that the social determinants of health matter more. Talking to them during the call matters more. We talk significantly more about the quality of a call and the quantity of a call that's done in the day and what the root causes are related to it. Of course, it's something that we're monitoring and figuring out how that equation would work. Like, is what we're doing going to equate to how CMS would measure it? Because we believe we're doing the right thing. We believe we're working so hard on trying to resolve those factors and assisting the member and collaborating with them, and even focusing on those, again, like you said, that maybe are a little bit riskier. I mean, we have areas of the state in Arkansas that don't have cell phone service, that don't have internet. And I know that sounds crazy in this day and age, but it's true. Drive around the state and you'll see that we have to act differently. We have to engage with them completely differently. And I think the hope is that because of the additional work and the additional efforts we would put in, the equation that would be put in for a health equity index would account for situations like that. But honestly, I think until there's more details, we stand really strong behind the current strategy that we have and probably won't make many changes. But I think you'll see some people look at it when it comes out to say, oh gosh, okay, maybe we double down a little bit more here, or we focus a little bit more.
Yeah,
but it's hard to, honestly, it's hard to know right now. It's kind of that wait and see game. But we think is best.
Yeah.
Yeah, I think you hit on it, because I think the plans that end up being really successful here are the ones that right now are really digging in. They're looking at their numbers, they understand their situation, and like you're saying, understand Are there areas that we need to kind of bone up on now that we're pulling this data out, we're looking at it maybe in a different way? But I think, the ones that are going to end up being successful are the ones that really understand how their population works, how they're serving them, and being able to jump on those improvement opportunities early on.
Yeah, and I've never gotten to say this on the podcast before, right? And I might never get to say it again, but because Lauren is on, because Lauren just said that, so I'm actually from Arkansas, right? Originally from small town, rural Arkansas. So my hometown is called 56 and has 150 people in it. So shout out to everyone in 56 who's listening. But yeah, I can attest to those challenges in these rural states, right? And it's and I think in many times, it's like Lauren's entity. It's like the Blue Cross Blue Shield plans that serve the whole state, or at least many of these rural counties that a lot of other plans don't. They focus on the metropolitan areas, right? And so I do think some of the Blues plans have some unique challenges, and will and may benefit more from some of this health equity
maybe opportunities
stuff,
on
right?
some of that.
Yeah. Lisa and Micah, I want to so when we think about all this stuff and how it affects stars, right? We at least plan leaders are really close to which stars measures exist now on the Part D side, the PQA. So we have the medication adherence measures, we have medication therapy management, and we have the lovely SUP-D measure, right? That is undergoing some change. But I want to look forward, right? So plans are close to those measures; they understand those in and out. And when these final rate announcements and final rules come out, they pay attention to those, of course, and try to predict the future as to what's coming in 2 or 3 or 4 years. But in between there are measures on the display page right now. Some of them that have already been through rulemaking and are maybe ready to be a stars measure, this year, right? But can you guys talk about provide any insight there on? I know there are opioid measures on the display page. There are polypharmacy measures on the display page. I think there are a handful of them, right, between the two categories. If you were sitting in the shoes of Lauren, or someone in a stars role, where would you be focused, and where do you think this? What do you think might become a stars measure in the future, as much as you can share? Realizing you don't know for sure, but
Yeah, sure. We don't. Yeah. Yeah, and I'd be curious what Lauren's perspective is. Yes, there's 5 potential display measures that could be star rating measures in Part D through rulemaking. 3 of them are opioid measures, and 2 of them are polypharmacy in older adults. And I would not anticipate more than one opioid measure, if there is an opioid measure in the star ratings. And likewise, I would only anticipate 1 or 2 of the current display measures moving forward. I think that CMS will proceed cautiously. Their medication safety measures, the flip side is, balancing out potential for unintended consequences. So I think one of the important things to do will be to look at the stratified rates of those measures along with the star measures to see beyond average measure rates, what populations, subpopulations are falling through the cracks, and where can you drive improvement there? Because if you think about the future of the emphasis of stratification, potentially public reporting of stratified rates, health equity index, definitely paying attention to those aspects of these measures, which do exist, is going to be essential. And Lauren, I'm curious your perspective.
We have very similar perspectives, Lisa, relative to the potential of an addition. All 5 sit there. They have been there for a period of time. And even after high-risk medications was removed, and I think we all expected one to kind of quickly join soon after based upon some initial language, or just around the fact that there really isn't a measure kind of that area right now that sits within stars. It's still remained on the display page. It still remained available for monitoring and, of course, for review by CMS as to performance, but we haven't seen it move. But again, if I had to kind of follow the same guess as you, I would probably guess one of each at best case scenario, but still uncertain at this point. I mean, even the kind of final announcement and everything did not indicate a move of either one of the two of them. And we would have kind of expected that if we were going to see it in the very, very near future.
Yeah, we could take some bets. I think that would be fun.
Well, and I'll just add, I think one of the unique places where PQA fits is our relationship with government agencies like CMS. They're also at our table just like our health plans are and our pharmacies and PBMs and tech vendors. We do have a broad table, and that allows us to capture information from our members and to share it with CMS in a very de-identified way. And so while, it's anybody's guess what CMS is going to do, and we usually find out exactly when everybody else does through their notices and things like that, what we do have the ability to do is to communicate on an ongoing basis with CMS about what we're hearing from our stakeholders and our members. That's kind of a unique role that PQA plays here as an intermediary. Obviously, we're a neutral entity, and so we don't take a lot of positions on things, but we do like to communicate what we're hearing from members like Lauren and how measures are being applied and what updates CMS might need to consider. We communicate that on a fairly frequent basis. And so that's one of the unique roles that PQA plays that I've come to appreciate over my time here.
Yeah, that's a really good point, Micah. Micah and I have even done some kind of semi-structured interviews and de-identified and provided some really rich feedback to CMS that isn't available through public comments. And so it is nice to, we're not taking a stand, we're just collecting this information, and it's very useful. It's insightful for us. And, in addition to, we thoroughly review public comments that CMS receives on our measures and combing through them right now, actually, and act on them.
And I'll just affirm how I don't know, the collaboration with PQA, it's something that's been important to me, and I really appreciate even you being on here and the transparency and just providing some visibility to plans who maybe aren't members, who maybe aren't on the panels, the technical panels, the development panels, like people like Lauren are but it's really important, and I appreciate how collaborative you guys have been. And Lauren, another question for you, like if I know we're mainly talking PQA measures here, right, and kind of the future of PQA focused measures, but not entirely. And as we talk like pharmacy measures in general in STARS, there's some bleed over into some NCQA measures that are maybe technically Part C measures, but they have a pretty important pharmacy aspect. Just curious from a plan perspective, from a pharmacist perspective, right? Someone obviously very experienced, invested in STARS. Are there any that keep you up at night? Any of the future NCQA changes related to pharmacy changes that you can talk about?
Yeah, I mean, I think sometimes they all keep at night. It just depends on the measure and which night. But it was interesting. If you looked at the final announcement, it said SPC will pretty much remain as it is. That they're looking at a couple key changes there. They're reviewing updated recommendations around PCSK9s, coding statin intolerance, and how to consider it. And so for right now, it's going to remain pretty steady. I think that measure is one everybody focuses on and is kind of a priority item because it doesn't just bleed from the SPC measure. It also obviously then impacts the medication adherence to statin as soon as you get that second fill of a pharmacy medication. And while I would say there's related to pharmacy and not directly pharmacy, I think the diabetes care measures are very critical to watch the changes. I think we're seeing statements from NCQA regarding those. We already see some changes that occurred this year relative to the kidney screening measure and other factors, but also the fact that NCQA is looking at what's the A1C over time. Is there a way to measure that? Are there factors to consider? There are a few key factors for that long-term A1C: diet and exercise and medication. and adherence to the medication and being on the right medication. So there, all of those coming in together, we consider, as much as A1C is a clinical outcome measure, we consider it almost just as much a pharmacy measure. And the team and collaborate honestly extensively with pharmacists. Inside of our plan, the pharmacist as actually the one who works the A1C high risk patients for us. So those are ones I think that we're carefully watching. Obviously, of course, always looking at that osteoporosis measure, but we're really closely looking at those too.
That's great. That's helpful. Yeah, thank you. In, anything we didn't ask today that we should have? Any other key topics you guys want to touch on briefly before we go? Any more forward thinking thoughts or any thoughts on that you want to share?
I might take this opportunity to share a little bit about what Lauren's talking about, and that's kind of pharmacy performance measures in general, and where PQA's focus there. As we look at closing the loop on care, we know there's providers that could be engaged in this process, and both collecting the information that's important to plans, but also providing the care at the point of access. And the COVID-19 pandemic certainly exposed some of those challenges, but also created some opportunities to engage providers in care. And so we see a lot of opportunity there. We launched some pilots earlier this year focused on A1C improvement and control, blood pressure improvement and control, those things that really hit both the patient at the point of care, but also the health plan and their quality ratings, and trying to figure out how to re-envision that to where how we engage pharmacies in that process of both doing the screenings but collecting the information and trying to drive that quality of care. There's other opportunities that we see around immunizations. Obviously, COVID vaccinations have changed a lot of things, and where patients go to get COVID vaccinations. The fact that 2/3 of COVID vaccines were given in pharmacies. It means that we need to focus on pharmacies as points of access. And so PQA is really invested in that. Obviously, there's a lot of collaboration between measure developers and organizations like NCQA that work through this process of collecting this information. So more to come there, but it's an area that we're keenly focused on, and where we see a lot of opportunity to really build out value-based care in a way that makes sense for everybody involved.
Yeah, and I want to add on that we really see pharmacists as an access point to address those social determinants that we've been talking about. And whether or not we can develop a measure in the short term, we are really interested in research related to that, demonstration projects, pilots, really advancing access to care and communication of factors between pharmacists and payers.
Yeah, that's important. Go ahead, Lauren.
Oh, I was just going to agree. I think a lot of times, and most people who work in STARS know this, it's not one area that's going to solve it. It requires such extensive collaboration across the entire healthcare industry. And that's certainly an opportunity, is that collaboration level with pharmacists, whether it's through programs that focus on A1Cs or other diabetic screening areas, or resolving social determinants of health. There's no provider typically that a member sees more than their pharmacist. And if there's that opportunity to gain more information and to learn from them, I think that's certainly a valuable opportunity.
I would love to see that. I've definitely been involved in some programs with community pharmacists and yeah, understand the impact they have and the influence they have and the role they play, and I would love to see measures develop that kind of help tell that story, right, or help measure that effectiveness. So that's great to hear. Well, hey, thanks so much. So PQA, Micah, Lisa, thanks for all you guys do on the measure steward side and being great partners. Lauren, thanks for all your feedback and insights today from the plan side, and we really appreciate it. Great conversation, and I think that's it, right? Anything else, Mick? Anything else?
I think you wrapped it up well. Yeah, that's it.
All right. Thanks, everyone. We will talk next time, okay?